So our next conversation is going to be about the government. The big thing that the government is right now doing, among others, is realizing the universal health coverage. It's one of the 5 big agendas of the Kenya Kwanza administration. We keep talking about them. Number 1, all of them are to improve the economy, create jobs. 1 is agriculture. Support the agriculture from all the way from production into value addition, into development of markets, into making sure that then more people are employed in there. Housing, improve the level of quality houses that we have in the country. It'll employ people, it'll bring down the cost of houses, we'll have better people living in better houses. 3, MSMEs. Make sure that you support MSMEs in whatever angle. Hustler Fund and others. Access to credit, access to markets, access to opportunities, MSME development. For all those to happen, you need to have a healthy population. Now, healthy population is where UHC comes in. Support universal access to healthcare. What is that? Access to affordable and quality health services across the country for everybody in the country. And the digital superhighway, which then comes to support all these things by making sure that you have access to the digital superhighway, which gives you access to job opportunities where you're working from here, and Kenya becomes a hub for international jobs, business process outsourcing, that you can also do all these things. You can then have access to Wi-Fi from wherever you are. All those things. Those are the things. Today, let's talk about this UHC because that is where we are. Senior advisor to the president in the Economic Council of the President, Moses Kuria, is our guest. Good morning, Moses.
Good morning.
How are you?
People. Very good.
Yeah?
Yeah. Good to see you again.
Good to see you as well.
Yeah.
You're keeping well?
Keeping well.
Sasa hii role ya senior advisor. Why senior?
Well, because they are junior. Only for that reason. That's simple. I mean, if they are junior, they must be senior, isn't it?
What's wrong with what's wrong with you? Don't you understand English? What kind of question is that you're asking?
There must be somebody
exactly.
above them.
Yeah.
What are you talking about?
Yeah.
Sawa. We live in the city. Please give me a senior advisor.
Okay,
Today's proverb.
Let me give him a senior proverb.
Okay.
Our proverbs for the whole of this week are from the Gambia, the Republic of the Gambia. Okay. If you stir up water in the pond, you will bring up the pond.
If you stir up the water in the pond, you'll bring up the pond. What's the interpretation of this one?
I think, there is no pond and the water. It's in the water, the pond, isn't it? Yeah. So the water is the pond. So if the water comes up, the pond comes up, isn't it? Yeah.
So if you stir up the pond, are they telling us it doesn't matter?
No, what they're telling you is that sometimes it's better to leave things the way they are. You avoid trouble. Yeah. You might think that you are stirring up the water, and then you bring up the pond itself. Yeah, you bring you get more than you bargained for. So be careful.
And this requires wisdom.
This requires wisdom.
Indeed.
And this world requires a lot of wisdom. A lot of wisdom.
On a daily basis.
Every time. Every time.
Moses, last year, this month, you were in the cabinet.
Yeah.
And a couple of months prior to this, you had sat in a cabinet, I presume, that had looked at several bills that were geared towards universal health coverage.
Right.
There were 4 bills that were taken to Parliament, they were passed by Parliament, and were assented to this month. And the President in Kericho said, now 4 laws are in place, we are launching universal health coverage, part of our promise as a Kenya Kwanza administration.
Yes.
Since then, there have been conversations. We actually have had conversations here with people from the Ministry of Health, from advisors, the presidential advisors on matters of health, from NHIF. Then the SHA was established. We had a conversation with the first chairman of the SHA, to a board member of the SHA, who then became the chairman of SHA. He has also sat here as chairman. We have had conversation with the cabinet secretary, principal secretaries, and now we are in SHA. And these are the headlines we are seeing.
Nightmare. Let me say this, let me put this in context. For the last 3 decades, I've been involved in so many project implementations across many countries. Many countries. I've worked locally and internationally. And this is a huge project by any means. I'm happy that even we are talking about a nightmare. and we have got a project right now. Let me say this because when I was appointed by the president to be, as an advisor, I picked on 3 priorities. One of them, I'll talk to you about the others, one of them being health, because I do believe that this is a very important project. If you look at the other projects that we are implementing, last year we implemented our agriculture project, the fertilizer project, registered 6.3 million farmers onto a digital system, delivered, a fertilizer for the first time using e-vouchers. I think you're just talking about Loop. Yeah. So now imagine if the same thing you're saying about Loop was being implemented about government, it could be defined as a nightmare. Yeah. So it's not unusual, especially for government, because government don't exist to be loved by their definition. You look at our education system, we've got a system that goes by the name of NEMIS, where all our kids are. Again, that's around 13-14 million. If you look at even the ones in the universities, you look at the money we send to our old people for the social protection money, 1.7 million people are in that system. Let's compare that now with what we are doing now with the SHIF. All 54 million people are going to be in one system. It is really the universal. When you talk about universal, you're talking about 54 million people joined in one system. It is bigger than the National Registration Bureau system, the one for the IDs. Because again, if you're not 18, you're not in that system. So never before in the history of this country have we had a system that encompasses all the 54 million customers. All of us, me, you, my mother, my child, all of us together. So it is natural that in the system, even a small one will have some problems, hiccups. So let alone this one, where it's supposed to be all of us, bigger than agriculture, bigger than school, bigger than ID system.
Yeah.
If people talk about Maisha number, this is the real Maisha number. And for me, when I look at this system, it is not about health. Health is just a byproduct. It is the first time that we are going, it is actually what I'm calling a system for law and order, whereby, I remember when I was working abroad, when I got my son in Saudi Arabia, and he was registered in a system, and then I bought a car, and the car was registered in the same system, and then I bought a dog, and the dog was registered in the same system.
Did you actually buy a dog in the system?
Yes,
Okay.
The system. You have to.
Just checking.
Yes, yeah, because you have to. So
the dog, car,
son,
same
system.
Same loan, same system. Yeah, that's I like really your opening remark, because that's it now. Once we get this right, this is the health is only a byproduct. We can have a system now that is predictable.
It's fantastic.
That you can be able to say, who is Moses? Moses is son of Teresa, my mother, who can be tied to me in the system, and is the husband of Joyce, and is the father of Brian. And Brian is in this school, and grandmother, despite Moses being a senior advisor, grandmother is in the social protection system. How?
Well, actually, I actually agree with you.
Yeah,
I think that it is a fantastic system.
Yeah, absolutely.
My question,
I really want us to be driven by the opportunity, by the good thing, not by the hiccup because we are bound to have these things. But once we get it right, it is unprecedented.
My question is this, because you're right. You are right. And I think that there are several countries that have a system like this, just like you've said. My question is, though, that why wasn't it practiced for some time to see how it would work before you stop a system that was working and serving people and start on another one which is presenting with more than hiccups the issues that Kenyans are going through today? Would it not have been possible to pilot this thing? Because like you said, it's a grand thing. It's not a small thing that you're talking about here. Why didn't why was there not the option of saying, let's have this thing running concurrently with NHIF for some months?
But
let's see how we can migrate people. Let's see how it would actually work before we now plunge people into the more than hiccups that we are seeing today.
you're actually drawing me back to my forte of implementations. This is my cup of coffee.
Yeah.
I am a fan of, and I'm a firm believer of coexistence of parallel systems during implementation, so that you reduce the risk of failure of projects. But I'll tell you two things. One, we are already in a parallel mode. NHIF is still in place up to, for example, as an institution, up to the 22nd of November. So we are really, there's really a lot of coexistence happening, even as we speak right now.
Not for the provision of healthcare.
No, it is. Nobody, we have said clearly, nobody is supposed to be turned away for whatever reason. But whether they have paid, they have not paid, as long as you are registered, and for as long as the facility is registered,
yes,
nobody is being turned away. Last night, I got a complaint from one of our advisors, Dr. Duranira, coming from Meru. And there was a memo from somebody, I think a CAC in Meru, saying now you pay for cash. You pay cash for some
service.
For some services. And I sent it to Governor Kawira Mwangaza. This morning I've had a discussion with Kawira when I was coming to this studio. And she said she was not aware. Yeah? So there's going to be a lot of those things of fine-tuning. What I would want, and that's why even we are going to work with everybody, with the stakeholders on the ground, with the media, with everybody. So the only way to solve some problems is through what I call iteration. It fails here, you fix it there, you fix it there until you get it right. So simple answer is already we are in some form of coexistence. Two, if you have been contributing to NHIF, there's portability of your contribution. So you are covered until the last point of your contribution to NHIF.
Okay.
So that's really some portability. That's really coexistence. You are carrying that with you.
Okay.
Yeah? Three, and this is more fundamental. We had experience in the fertilizer program, and I was right in the middle of that implementation. In the previous government, in the last year of the previous government, the people who received subsidized fertilizer were only 20,000 farmers. The ones who are claimed were in the millions.
Hey.
Sometimes a system is so rotten that, coexistence, is actually like saying, why can't I live with the cancerous wound and a septic wound? And
as I heal.
Do you know the mess that has been there in NHIF, my friend? A small hospital, has done more dialysis than Kenyatta National Hospital for a whole year, and claiming and being paid for that. A hospital has done more amputations and being paid for that more than Kenyatta National Hospital. Men have delivered children, and hospitals have claimed and have been given money for that. Sometimes, unasema kama ni mbaya, because the road was just too much. And some people are saying, why NHIF? Why not? I heard even on radio yesterday, which is about to happen, I heard some people saying, waturuhusu tubaki kwa NHIF. Then I said two things. I remembered it was the same thing when the children of Israel were leaving Egypt. Along the way they were saying, it's better Pharaoh,
We're at Pancus.
You are even, easier. If they know what they are saying, we'd go back to. And you know what? Even when the car was invented, people said they wanted faster horses. Why are you bothering us with the car? So there are cases of people being comfortable with the old and what they are used to. But the reality is, once they get used to the new things, to the certainty, and I can take a whole day talking about the differences between the old and the new. But the best way for us to convince the people is experiential.
Okay,
Exactly.
Please, let's look at the issue on the ground.
Yes.
Because we can talk about coexisting programs and parallel programs, which I'm a huge advocate for, until you know that one is foolproof. Now, because we did not know, or we did not practice one in a state where it was foolproof, we have situations whereby we have women, men, who are in need of critical care, Moses, who are not getting it today. Day 1, day 2, we're going into day 3, where because one system has not carried over to another, they're actually not receiving the care that they need.
It's not a system issue.
So
it's
what is
a
the
people
issue? What's the issue?
It's a people issue.
What's the issue?
It's a people issue. It's a non-compliance issue.
By the providers?
By the providers
they're
on the
not
ground.
complying?
They're not complying.
How?
Yeah, because we have said very clearly, nobody who is a member of Chief Shah from a licensed, contracted, as we are calling it, facility is supposed to be turned away. And what we are doing is that we have got a hotline, we have got a call center. We are going to actually, I'm just heading from here to our contact center and ensure that today we publish the hotlines, the call center numbers for anybody who is being turned away for any reason. Because when those people are turned away and they contact us, and we're going to have, to publish all the touch points, whether by SMS, whether by WhatsApp, whether by anything, of all the people, these cases of people are being turned away, you're actually doing our job. Because you'll be helping us to be able to identify the non-compliance point. Maybe sometimes it's I'll give you an example. A senior member in government, he's a director somewhere in the ministry. He called me yesterday and told me, I think I want to help you because I think there's a problem of the system. There's something we are calling means testing, where you're supposed to be assessed on your means, how much you pay. He's on a payroll. Yeah, so 2.75%, the means testing is working. Then he told me, how come my wife is the assessment and she's not working, is coming too close to my, because him was getting around 5,000 shillings assessment, and the wife was getting 3,750 assessment. How come this me who is employed is getting very close to...
And the information she has inputted is not showing that she has any income.
That's really the problem. Then I said, look, so I'm just, why am I talking about this?
Yes.
To show the need of people reporting, so that we use the reported cases, realizing that any system is about to have issues, to iterate, and we use it now to make the system work even better.
That's the case for piloting, isn't it?
No, it's a case of, it is different because no system can solve that. You know why? Then it occurred to me that even me, I don't think I was using my brain properly, because I didn't ask myself, how can this guy be assessed and the wife is assessed? And that's a household.
It should be a household.
It should be a household. So it turns out that the guy never linked. Before he went for means testing, you are supposed to link your dependents to you, so that you become a household. You become a unit.
Right.
Yeah? So
information.
What God put together, the system put asunder in this case. Because you're supposed, so you realize that
there are several things that are coming out here. Key among them,
key among them is communication.
Is information.
Information, yes. I agree on that. On that one, mea culpa.
So let's go back into
and
this.
We will work on communication backwards, and because we have to actually segregate issues of information with issues of the system and the technology working. Now, issues of information is about two people. It's about the person who is supposed to be giving information
and the provider,
and the person who is supposed to receive the information. Be them provider, be them the member who is covered, and we are work in progress. And you know what, Eric, from where I sit, I am over the moon about how successful this implementation has been, given the magnitude that the issues now. Every day I'm tracking the number of issues. And if you go to my social media, I am really tracking the numbers as they come up and publishing every day. I am, from today, I will start actually saying not just the good things, but also the bad things. Yeah, because that's how you improve systems. That's how you improve life. You improve life by iteration. I am surprised by that until now, we're talking about 1, 2, 3, 4, 5 numerous issues that we have to deal with. Which, in my opinion, in the next 2-3 weeks, if we just keep on, tightening the screws on those issues, then we are going to have a very good system.
Moses, those service providers who don't have information, what they don't have information on is this migration and how it's working, how they document that Moses has come to my facility and that I have given Moses this service, and therefore I shall claim. Right? Because, like you've said, the history has been that there have been issues of fraud. And the main suspicion here will be, if you just come and say, on Monday, there was Eric, there was Ndu, there was Moses, there was City who came to my facility, and, the system was down. They were telling me that they have transferred, and I looked at them, and I looked at the government instruction, or provide a service, so here they are. The next thing, the ministry official will be like, how do I know that these 4 people came?
You see, now
do they have information on what they are supposed to be doing? Yes, they are supposed to accept the people. But how do they document that these people have come if their system integration has not worked on their end?
Now, let's talk about that word, system integration. Right now, we are not requiring facilities to do system integration. I think it's very important to notice that. We have got 2 kinds of facilities. Facilities which had their own systems. Mostly level 5 hospitals, big hospitals. They had private hospitals, faith-based hospitals. Those ones had the luxury of having their own, what we call hospital information management system. That is where the issue of integration would come in. There is the other category of hospitals which didn't have any system at all. Now, where we sit today, whether it is the big hospitals, the lucky ones who have got their own systems, or the ones which didn't have a system, in this first phase, we are not even looking at their own systems. The what we are calling the provider portal, which can be directly accessed through a link, through a URL. You go in there. That's where the patients are being registered. That is where services are being offered. It is not really an end-to-end. Again, coming back to my sister's concern about the coexistence. We are coexisting because we are using their old systems as they are, but we're saying, please go directly to the provider portal and log in all the patient information and all the treatment information. And it is there that also they are going to load their claim. This time only, not by a piece of paper, but electronically, through what we are calling the e-claim system. Now, I know over the last 2 days, the e-claim was mara up, mara down, and that's all the problem. I can promise you, Eric, you are lucky, me and you are lucky that we are sleeping maybe 2, 3, 4 hours a day. There are some folks there who've not slept for a whole week. Not a single minute of sleeping. I know even up to last night, the team that is working on e-claim, they have burned the midnight oil to ensure that today at least, on the e-claim, we're able to settle the claims and we're able to discharge patients today. If you come next week, you find this whole system for the claiming working seamlessly. Very few people will remember the kind of problems that we have come through with. So all I'm asking, please, is because the good things that will come from this system far much outweigh the labor pains that we are going through right now. Let Kenyans invest even their emotion and their support somehow to bear through the kind of hardships that we are going through, because just like labor pains, the product, the baby when it is born, is going to be pleasant, and it's going to spread joy to everyone. So the small inconvenience of the labor pains is something that we should bear with. And by the way, this is not without precedence. I remember during fertilizer, there was hue and cry. When now the price of hunger came down because our fertilizer and the pains that we went through that time. Nobody remembers the pains that were there that time. Just like a mother will not remember the labor pains. Yeah, they will just see the joy of the baby. Soon, very, very soon. And I think that's what you need to be talking about. So what are these wonderful good things?
What are the joys?
After, what are the goodies after we come through from the labor pains of what we are going through?
You said something very interesting, and you painted a very graphic picture of the rot that was in NHIF. Now, let's have this imaginary situation where the rot was eliminated and had not been there. Would the system still have required change?
Yes, because of one thing, and I like that question. What we're implementing today, once we implement, it is important to ask ourselves, we will be like which country? We'll be on the same level as which country in matters health? And the answer is very simple, like none other. Not even in the United States.
Mm-hmm.
Nowhere else, not even in India, nowhere will be like a country with no parallel in terms of healthcare. This is M-Pesa 2.0 in terms of global something.
Leapfrogging and leading the world.
Yeah, why? In other countries, you'll find a very good public system. In the UK, for example, they have what we call the NHS, the National Health Service. As we speak, there is a waiting queue for months. Some of the operations, if you want them at the NHS, there is a waiting queue in the system for months. And that is for public hospitals only. There is nowhere in the world where you'll find a system that connects from, not even from the lowest facility. Let's start from the lowest. Do you know which is the lowest level of unit of hospital that is going to be in SHA?
Mm-hmm. It's a domestic, it's home.
Home. Thank you very much.
Uh-huh.
Thank you very much. From home.
Mm-hmm.
From home, the home is now a hospital. Yeah? All our households are now our hospitals connected in the system.
Mm-hmm.
A doctor known as CHP, community health provider, still in the system. Level 1 hospital, dispensary, level 2, level 3, level 4, level 5, level 6, all the way from Kenyatta all the way
To home.
to a homestead in a place called Kanyamkago, connected in the same system. Yeah? In the same system. Yeah? Never seen. 2, a system that connects both private hospitals, public hospitals, faith-based hospitals, all in one. Never seen that. Never seen that. Because right now, and by the way, some people are telling me, I had an argument to someone from Embu over the weekend, telling me, now, this SHA cannot work unless now we improve the facilities in our, the services and the facilities we uplift in the public hospitals. I said, I wouldn't care less. I said, why? Because now, once you are covered, you come from Mama Lucy Hospital to St. Francis Hospital, one is public, the other one is private, without a care. The package is the same. You go to public hospital, you go to private hospital, you are covered in exactly the same way. So you go to Mama Lucy Hospital and you find that the accused is dilapidated, people are rude. You simply go to Ruai Family Hospital and you get the treatment there with the same package as you'd have gotten to Mama Lucy. So what will that do to our public hospitals? What that will do is that now the game is up. They have to up their game or they disappear from the face of earth. Luckily for them, one of the laws we passed, as you mentioned in the beginning of this show, the Facilities Improvement Fund is available only for the public hospitals. Why is the Facilities Improvement Fund necessary? It is actually an affirmative action. Realizing that the private hospitals will overrun the public hospitals, it is telling the public hospitals, governors, please take this money, go and improve your hospitals. And if you don't improve your hospitals, patients will vote with their feet and they will go to where they can be able to get good service, and so they'll go to the private hospital. So if you look at that, again, patient data portability. I come from my village dispensary, same data. I go to Gatundu Level 5 hospital, same data. I go to Aga Khan, same data. I go to Kenyatta, same data. So all these whereby, and it's on your phone. You can be able to use your phone and say, look, or this date I went to Karen Hospital, or this date I went to Mama Lucy, or this date I went here, I did that. Another thing, my good friends, the doctors, and I warned them during the doctor strike. Now, this thing of going to Kenyatta for 2 hours and then going to your private to meanguka na wao. Yeah, because now you go to Kenyatta, you log in. Every health worker will get a device. They have to log in. So again, and it will be publicly visible. Dr. Eric Ratif, morning, 7 to 9, Kenyatta. 9 to 2 p.m. sijui Latif private hospital 10 to 11 sasa you have to decide you are a public doctor or a private doctor. So if you look at coming back to that question, City, if you look at now that compared with the NHIF, it's actually like they say where I come from, comparing death with the sleep.
Okay.
It's not, it's just two different animals altogether.
I agree completely. It makes perfect sense, and I like the picture. A small problem here, though, because even with the system upgrade, because this one is a mega system upgrade, but it will be run by people. The route we speak of is not mechanical. It's not digital. It is people and their ways. How will we avert this same issue with the
people that we have?
Yes, because this program is going to be implemented by Kenyans with Kenyans. And the people who gave us the rot in NHF were Kenyans. We didn't import them, and now we're deporting them. Same people.
I like this. I really like this because the question you ask is really at the heart of the system. When I was a student of finance and accounting at the University of Nairobi, Professor Nzomo taught me one thing, that fraud is a formula, and he gave me a formula. Fraud is equals to ability multiplied by opportunity multiplied by desire. Please note that one. Yeah? Please note that one. Yeah?
Ability, opportunity, desire.
Ability, opportunity, desire. All of us have got ability to be good thieves. If you want to be a thief, you just use your brain, you can. Most people, many people, not most people, or a good number of people, have the desire to cut corners and do bad things. The ones that you are describing, it is describing. The only thing at your control is opportunity. And what this system does, it minimizes, may I dare say, it brings it to almost near zero, the opportunity to commit the things that were being done. So I can run this system with exactly the same people, or most of the people who are running NHF. But my friend, I have given you the example of doctors. I have given you the example of people that claims. I have even told you about medicines, which were being taken from KEMSA. You find when we are ordering from KEMSA, the system is working. Ikifika kwa hospitali, the system inafungwa. The medicines are received manually. Jioni unaikuta hapo kwa Kamutaini Hospital. Hapo nyuma. Now we have tightened because now even the KEMSA system for the commodities and even the Pharmacy and Poisons Board for the tracking and tracing of the commodities is locked in the system. So this system was not made for good people. And it was not made for mature people.
Okay.
This is a system we have made for thieves and for children, for kids, for idiots. It's not for clever people. Yeah? You know, it's what we call in technology a system for dummies. We have created a system for dummies. We have assumed that everybody, unlike the rules of natural justice, everybody is a thief until proven otherwise. Yeah? And everybody is an idiot until proven otherwise, you know.
Okay.
And that is really the ideology behind, you know, the way we have programmed, this system, that knowing very well human beings are prone to temptation. And if the human beings are prone to temptations, Kenyans, as a special species of human beings, is even prone to more temptation. We made a system with that ideology, with that frame of mind.
Okay. You mentioned some of the things that used to happen under the NHIFs, and that was, we do know that, you know, riddled by graft for years, NHIF, it was, you know, people were taken to court, things like that happened. Apart from some of medicine moving around, what were some of the things that happened on the NHIF that this system essentially is going to shut the taps on so that we can understand that from what you see? But before you answer, I would like your reassurance that I still am worried about people who are going to seek care today. I would like a reassurance from you that people will be able to get the medical care that they seek when they go to facilities around the country, regardless?
Let me start with your second question. I just wish that I could give my personal number on air, but because nilisalimiwa na Gen Z
wako nayo.
So wako nayo, sisi wako nayo walinisalimia, anybody can feel free to even, that's how much sure I am that we can solve any problem. Am I saying there is not going to be a problem? No. And as I'm saying, by cross of business today, we will be able to publish, on the social media, in the media, and by the way, very soon, in the next 1 week or so, we are starting our two things are coming up, and I want to talk about that separately. We're starting with our media campaigns, so we're able to use the media to sensitize and to be able to pick up these things. But for now, today we are going to do what I'm calling crowdsourcing of issues by publishing our hotlines, our touch points for the complaints, so that we are able to ukifukuzwa and you think you have been fukuzwa, unfairly. Bring it to us. Now, let me come to what was happening in NHIF. The funny thing about NHIF is that what was happening was not visible to the patient. By the way, people, NHIF is a good brand. Our people trust NHIF.
Yes.
Our people love NHIF.
Yes.
Yeah, people love NHIF. I've said that in meetings.
Yes.
People love NHIF.
Because you got a service.
But little do they know, lo and behold, what was happening there. But then we don't have, well, let me be kind and fair. But, okay, let me just give the order. One, when you go to hospital and you are treated by NHIF, you have no idea that the money that you have been paid for, you could have been paid for 2 or 3 times better if somebody else who did not deserve were not paid for. Of course, fraudulently. The false claims is a big cost. It's a huge cost in the system. Yeah? And it's a collision system. It's a collision between the worker, the facility, somebody at NHIF. Now, you as a recreative, you know that I got my treatment and I was able to pay this. What you don't know is what you could have gotten. So it's a case not of system failure. It's a case of missed opportunities. That's number one. Fake amputations, fake CS, and all that kind of thing. 2, and I'm very happy with this one, is the universality. When we talk about universal health care, we talk about a principle called egalitarian principle, where there is no George Orwell here. George Orwell. Where all animals are equal, but some are more equal than others. Nowhere was George Orwell more manifested than in NHIF. We people called public servants, especially the senior ones, we used to have something called enhanced package. This enhanced package was being paid for by you, taxpayer, by you, the other NHIF. For every 100 shillings that NHIF was paying out, 35 shillings was going out for my comfort as a public servant. Now, the only unfair thing is that we are only 1 million of us. People who are were employed by you guys, by taxpayer. You are our bosses. We, your servants, 1 million servants, used to take home 35%. You, our bosses, 53 million of you who love us so much, were getting the 65%. This is not an economic issue. This is an ethical issue. It's a moral issue. Yeah? And right now, where I like the SHA thing, they're saying, if you public servant go and get some other money elsewhere to treat yourself, don't come and mix it with us. It's like vomiting on, now this is other taxpayer now.
Deal with it.
Huko kwenu. In under SHA chief, the president, Mama Mboga, Eric Ratif, City, everybody will be treated the same. For me, this is a huge movement. Yeah?
So quickly, there are 2 things that you said you want to talk about. One of them is the public sensitization.
Public sensitization, that is number 1. Number 2, now there is a missing blocks of implementations on the ground. As I've told you now, we are going to the ground. Now what's happening now is that people are going straight to the portal of SHA, to the health providers portal to put it there. We still have got some things to do. We need to take, we have got a free of charge hospital system from dispensary to level 2, to level 3, to level 4, to level 5. All they need to say is for the public hospitals, come.
Free.
Free.
Free from who?
Free from the government, from the investor. And that's another thing I want to talk about here. If you go to any hospital, once we start rolling out to the Kuja Kwako, we ask you, we want to give you a free system with free devices. Every healthcare worker, we are providing the device from where they'll be working for free. 70,000 of them are on the way here. This is a huge, very expensive project. Yeah? And when people talk about, 104 billion, it is not government money. Because you couldn't afford. Just like we can't afford many things in this country. We are giving free information system, free device. By the way, the healthcare system is the biggest ICT. We talk about digital superhighway. The biggest ICT project we have in this country is this healthcare, which we are calling Taifa Care. You know why? Because every hospital will get internet, Wi-Fi, or thereabout. So even if the healthcare does not work, God forbid, every corner of this country will be connected thanks to this project. Every corner of this country, because we have to get power. We are getting power. Kenya Power is working on a list to get power to free again there. So we get free power, we get free connectivity, we get free devices, we train them for free.
How long do you give this project? How long?
I think that process, I'm giving it 12 months to be in every corner. To be in every corner.
Each of the 70,000 healthcare workers has a device.
Have a device and is connected to the internet and gets power there. And by the way, it's not a device only for the hospital. See, that now village now will also benefit from that Wi-Fi. See, when I do power, even areas which are not connected. So this is what I would call a catalyst, a trigger to be able to implement this. And that is why I'm saying when in the fullness of time, people realize that the good things that come with this is more than health, is actually connecting the country. Latif, I'll tell you the things. We get this system right. First of all, already, I'm telling you, the education system, the one I said where our children are, it is making noise when we try to integrate with this system. Because the data in the education system is telling us another very funny story.
Nemis has fake children.
Hiyo ni story another day. Hiyo name sasa
has ghost children.
Ghost sasa imeanza kujireta because ingine inakuonyesha watoto wengine ambao sio wako na sio mpango wa kando. So all these things are starting to come to the fore.
Moses,
right
would you go to hospital today with a SHA card?
Yes.
Would you
Yes.
go to seek medical care in any hospital in the country today under this public system? Would you, as Moses?
Absolutely yes. Absolutely yes. And when I find problems there between this week and next week, I'll be patriotic enough to say I am okay. I've been treated, but I think we can do this better so that we work on this together as a country.
My only issue with Moses, and I like what you've said today.
Yeah.
But in March last year, when the laws were being drafted, this beautiful dream and picture was painted. In October, when President Ruto was launching it, this beautiful picture was painted. When the SHA board was established, this beautiful picture was painted. In October 2024, we are still painting a beautiful picture.
Now,
and yet we are saying we're
you're not
implementing.
painting
That's
a
my
beautiful
issue.
picture. You have shown me the headline.
Yeah.
We are there now.
We are
The rubber is meeting the road. Now it is not a story anymore. Thank God. You are showing me headline pictures of chaos. Now, from beautiful pictures to chaos. From chaos to wonderful things.
You know, we haven't had this conversation fully. When can you come back again?
My friend, this is my full-time job. Call me.
Very good.
Thank you.
Very good. Thank you very much. Moses Kuria, Senior Advisor to the President, has been our guest.
This is the Situation Room, the only way to start your day.